My name is Val Fonsem. I'm a colorectal surgeon at the University of Arizona in Tucson. Today I'll be talking about late stoma complications, non-operative and operative management. I have no disclosures. Depending on what literature you read, the overall rate of stoma complication varies significantly. This ranges from 20 to 41%. More importantly, nearly 50% of patients with stoma complications will require a stoma revision. The rate and type of stoma complication also vary depending on whether it's an ileostomy or a colostomy. Early complications are defined as those that happen in the immediate post-operative window. These include ischemia, hemorrhage, stenosis, fistula formation, and also stoma retraction. Stoma retraction is mostly caused by a technical problem. I will be focusing my talk on the late stoma complications. These complications are seen beyond the immediate post-operative time. Depending on the literature, the incidence of late complications ranges from 6 to 76%. These complications include stoma prolapse, stoma obstruction, hernia, fistula formation, stenosis, and also skin irritation. These complications are typically due to poor technique, poor care, and also management, and also some patient factors. Patient factors includes obesity and also other diseases. The first late complication I would like to talk about is stoma, stenosis, and stricture. The incidence of stoma, stricture, or stenosis range from 2 to 14%. Stoma stricture could be an early or a late complication. The most common cause of this complication is ischemia. This could be due to the blood supply being stripped off during the stoma creation, or the stoma fascia aperture being too tight, or as a result of a low flow state in a patient that is septic. Other causes of stoma stenosis include infection and also stoma retraction. The management of stoma stenosis include ruling out inflammatory bowel disease and also recurrent malignancy. The first mode of treatment should be stoma dilation, but most patients ultimately end up with a definitive stoma revision, which might actually include residing the stoma. Parastomal infection and fistula occurs about 2 to 15% of the time. Parastomal infection ultimately leads to parastomal abscess, and abscess formation may be due to an infected hematoma that was formed during the stoma creation. It could also arise from stoma revision due to contamination of the stoma site and also residual infection. Stoma abscesses could also be formed from folliculitis around the stoma, and treatment is usually incision and drainage of the abscess and treatment with appropriate antibiotics if there's any cellulitis. Stoma fistula formation may arise from the abscess, and this happened beyond immediate post-op, or fistula formation or infection could be signs of recurrent Crohn's disease. Fistula could also result from placing a serosal stitch in an inflamed bowel, especially when bruching an ileostomy. Stoma retraction occurs more with ileostomies than with colostomies. This is seen in 1 to 6% of colostomies and 3 to 17% of ileostomies. Stoma retraction is one of the most common reasons for reoperation and could happen due to tension on the stoma, patient factors like obesity, and also steroid use, which leads to poor wound healing. Stoma retraction leads to leakage and ultimately severe peristomal skin complications, especially with ileostomies. Special stoma appliances are usually needed to manage this, and the involvement of a stoma nurse is very critical. These patients with stoma retraction typically end up with a revision of the stoma. Stoma prolapse is also a common late complication. The incidence of stoma prolapse range from 2 to 26%. Transverse loop colostomies have the highest rate of stoma prolapse, which ranges up to about 30%. We also see a significant higher rate of stoma prolapse with loop ileostomies. In addition, stoma prolapse are typically accompanied by parastomal hernia. Non-incarcerated prolapsing stoma could be managed with reduction and also supportive care until definitive surgery, especially for patients with temporary stomas. Patient with incarcerated stoma requires emergency surgery. At times, a loop stoma might need to be converted to an end stoma and also possibly residing of the stoma. Parastomal hernia is very common. More than 50% of patients will develop a parastomal hernia if they have their stoma long enough. Some of the predisposing factors of parastomal hernia include the following: stoma placement lateral to the rectus muscle. It is important that the stoma comes through the rectus muscle. It is also important that the muscle is split and not cut. A large stoma aperture is also another cause of parastomal hernia. It's also important to keep that aperture just adequate enough. Obesity is also a cause of parastomal hernia. If a patient can lose some weight prior to surgery, that might actually reduce the rate of a parastomal hernia. Another cause of parastomal hernia could be prior abdominal incisions, also malnutrition. So it's important to improve the nutritional status of the patient with prehabilitation prior to elective surgery that would require a stoma. Wound infections have also been shown to cause parastomal hernias. Management of minor cases of parastomal hernia might actually just require applying an abdominal binder. However, reservation for surgical intervention is more for symptomatic parastomal hernias. Symptoms might include abdominal pain and also bowel obstruction. Symptomatic cases might not only need a revision, but might also need a relocation of the stoma. The literature on prophylactic mesh placement to prevent parastomal hernia is still very debatable. Skin complications are very commonly seen with stomas, especially with ileostomies. The incidence range from 3 to 42%. Skin complications could present in the form of mild skin dermatitis to full thickness skin necrosis. The most common cause is exposure of the skin to stoma effluent, which could be very caustic, especially effluent from ileostomies. Other types of skin complications can include contact dermatitis and also fungal infection. These complications could be prevented by using better fitting appliances. Treatment options also include improving cleaning of the peristomal skin, application of skin barriers, treatment with antifungal and also antibiotics, and application of stoma paste. Folliculitis is also another skin complication that is not really commonly seen in patients with stoma. The treatment for this is antibiotics and also keeping the area clean. A dreaded peristomal skin complication is pyoderma gangrenosum. This was first described as associated with Crohn's disease in 1970. The diagnosis is mainly done by physical exam. The peristomal lesion has a very characteristic cookie cutter appearance. Treatment options include wound debridement, injection with steroids, and also treatment with systemic steroids. Granulomas are not very common, but they are also characterized as peristomal skin complication. Granulomas are lumpy lesions that are formed due to inflammation of the dermis. They develop as a result of overhealing of damaged skin on the stoma surface, possibly due to friction from the stoma bag. Stomal granulomas may also be due to granulation tissue from poor wound healing and infection. It could also be formed from bowel metaplasia, that is the stomal skin morphing into a bowel tissue. You also see stomal granulation or granulomas in patients who have Crohn's disease. Some, but not all, stomal granulomas can cause bleeding and discomfort. In conclusion, a late stoma complication is very common, and complications rates also depend on the type of stoma, be it an ileostomy versus a colostomy. Complications are also due to poor technique and also poor care and management, especially of the peristomal skin. Late complications could also be due to a recurrent disease. Most complications actually end up requiring surgical treatment.